Virginia deputy, Dr. Smith works in coordination with the state health officers to set policies, directions for the department, and ensure that problematic responsibilities are met. Dr. Smith has a strong commitment to the mission of ADH to protect and improve the health and well-being of all Arkansans. In his role as Director for Public Health Programs, he strives to help colleagues achieve their full potential using public health best practices supported by science-based decisions. Because of his background and interest in HIV, he served as the chairman of AIDS Drug Assistance Program Formulary Advisory Committee and is also a volunteer clinical assistant professor of medicine in the Division of Infectious Diseases, where I met him, Department of Internal Medicine at the UAMS College of Medicine. Dr. Smith is board certified in internal medicine and infectious diseases. From July 2006 until he returned to Arkansas in August 2009, Dr. Smith served as Senior Medical Technical Advisor for the AIDS Relief Program in East Africa country, Medical Director for the University of Maryland School of Medicine, Institute of Human Virology in Kenya, and Infectious Disease Counselor at AIC Kajabe Hospital in Kenya. So he has a very wide and various expertise in AIDS and HIV, and so I bring him to you this morning, Dr. Nathaniel Smith.
Thank you. It's a real pleasure to be here. Can you hear me a little bit better now? It's about the same? Okay. It's a real pleasure to be here and get a chance to share a little bit with you this morning. HIV has been a passion for me professionally. Even though that's not the only thing that I do these days, it's the thing that kind of gets my heart going the most, the chance to help people who are living with or affected by HIV. I'm going to go ahead and move through some of these slides to keep myself on track so I don't use more than my appointed time, but I hope you indulge me if I get a little bit excited about some of what we're talking about. So this is 2011. AIDS is 30 years old now. Any of you here less than 30 years of age? Okay, so you've never lived in a world without AIDS, but it first came to the public's attention really in June of 1981, when the very first report of what later became known as AIDS came out in the Centers for Disease Control CDC journal called MMWR, Mortality and Morbidity Weekly Report. And it was a small cluster, 5 gay men who had a rare form of pneumonia. No one really knew what was causing it at the time. And over the next few years, the scenario unfolded. And here we are 30 years later. I'm not going to give lots and lots of statistics, but as state epidemiologist, I've got to start out with just a few. HIV in Arkansas, our latest numbers that are complete are for 2010. Since the epidemic began in Arkansas, we've had almost 8,000 individuals diagnosed with HIV. Of those, unfortunately, over a third have passed away. We have over 5,000 living with HIV in our state, and almost half of them have been diagnosed with full-blown AIDS. Now, as we go on, I think you'll come to understand that my perspective is that that's not acceptable, that we can do better. We know better, we can do better. Looking at the number of newly diagnosed individuals, those are in the blue bars, and then the red bars are those with AIDS, full-blown AIDS, advanced immunosuppression, people who are sick or very very great risk of becoming sick from HIV. You can see over the last several years it's been pretty stable. Fortunately, we're not in those early days where it was doubling every year, but we're not making a whole lot of progress in terms of preventing new infections. It's pretty much status quo, and I think you'll find as we go along, I don't consider that to be acceptable either. We know better, we can do better. Who are our individuals living with HIV in this state? Well, most of them are men, although growing number of women with HIV. A disproportionate number are African American, although we have representation from all of our ethnic groups in the state. HIV is an equal opportunity infection. So I've titled this Care, Cost, and Complications, so I'll start with care. Let's take a little bit of an assessment here. What do we have to show for the last 30 years? Have we made any progress? When we started with HIV or AIDS in the early 80s, when I first started taking care of HIV patients, we really looked at this as a terminal disease. It was like cancer. In fact, one of the early names for AIDS before we settled on AIDS, the name, was that they can't take antiretroviral therapy and have their HIV under control. So the majority of individuals living with HIV in the U.S. today either don't know they're infected, know they're infected but aren't in care, are in care, or are in care and not controlled. They're not benefiting from the promise or the hope of the progress that's been made. And so despite all these advances in medical care and antiretroviral therapy, we have more than 16,000 individuals die of AIDS in the United States every year. I think that's unacceptable. We know better, we can do better. In Arkansas, these are our most current estimates of the over 5,000 individuals who are aware of their status, and we know that there are those who are living with HIV in our state who have not been diagnosed. But looking at the about 5,300 who know their status, we have evidence that about 42% are receiving some kind of medical care or receive some kind of medical care for HIV within the previous year. As people develop more advanced HIV disease, the cost of care increases. So it makes a lot of economic sense to get people into care early, and it's overall much less expensive. So who pays for this? Some audiences that I speak to assume that someone is taking care of all this. Have you ever heard that? I hope if there are any here who assume that someone is taking care of all this, that your ears will prick up. Fortunately, most people with HIV, if we work at it, if they work at it, we can get them some kind of care. But it's not nearly as automatic a thing as one would like or hope. And I think that's borne out by the large proportion of HIV-infected individuals who are not in care. Overall in the U.S., Medicaid covers a little over half of people living with HIV and the majority of children who are living with HIV. Unfortunately, Medicaid is structured so that it doesn't kick in until people are disabled, and that usually means 6 to 12 months of disability. Well, if you wait until someone is disabled from HIV, they have full-blown AIDS, they can't work, they're sick, they may have permanent damage, and we've already seen the costs of taking care of that individual are 2 or 3 times what they would have been if you had started treatment when they were still healthy. By the time people qualify for Medicaid, they usually have advanced AIDS. And in Arkansas, for adults, it's really hard to get Medicaid coverage for any kind of disability.
You have to be really poor and really disabled. So, what kind of safety net do we have for the underinsured or the uninsured? Well, we have our Ryan White Care program, our AIDS Drug Assistance program, and fortunately, we currently do not have a waiting list for that, although that wasn't the case even 6 months ago. Many states now do have waiting lists for their AIDS drug assistance programs. Actually, there are thousands of individuals around the U.S. who are on waiting lists for AIDS drug assistance programs. We have community health centers which have limited capacity, charitable clinics, public hospitals in some states. And a lot of our patients are receiving their antiretroviral medication through pharmaceutical company patient assistance programs, which are really lifesavers. But they're not a guaranteed thing at all. Each company has their own criteria or who they will accept to put on, and you really can't guarantee that's going to be there in 6 months or a year. So we've got problems in the way that we're funding HIV care in this country and in this state. We've got fragmentation of coverage. We've got multiple funding sources with different eligibility requirements, variations in the type of services that are provided, even from the same program from one state to the other. May cover different things. I've had many patients come to me from another state and said, hey, this was covered when I was in Florida or Missouri or wherever, and it's not covered here. Or sometimes it's been the opposite. They've said, wow, you cover this, we never could get that before. We've got sort of a patchwork that's sort of sewn together out of old rags, it seems sometimes. And it's very difficult for individuals to navigate. Some folks get so frustrated that they just give up on it before they even try, which I think contributes to the large number of people who are not in care. And an Institute of Medicine report from back in 2004 said the current funding system does not allow for comprehensive and sustained access to quality HIV care, and the system has not changed since then. We know better. We should be able to do better. So, pricing. If I get up on a soapbox on this one, I apologize. Someone with a hook pull me down if I get too far out on a limb. But the prices for these medications, for all medications in the U.S., but especially for antiretroviral medications, have very little relation to the cost of developing the drug or producing it. As an example, branded Retrovir, the very first drug we ever had, AZT. Branded AZT costs over $500 per month, but now that we have an FDA-approved generic, the same drug, FDA-approved, $3.42 a month, okay? There's a company that can produce this, distribute it, and make money off of it at $3.42 a month. But the branded product has been selling for over $500 a month for almost 25 years, okay? Same for branded Xerit, which we hardly use anymore. Over $400 a month branded product, less than $8 a month for the same medication as a generic, okay? Typically in the U.S., you expect the generic to be a little cheaper, somewhere between 30 and 80% below brand equivalents. But in the case of these antiretrovirals, these are less than 2% of the cost of the branded product. And AZT, Retrovir, the very first one that came out, that drug actually was already in existence. I think it was actually federal dollars that had developed that drug as a cancer drug, and it didn't work. So the company basically found it, and then they were fast-tracked, to get something out there on the market very quickly. So their development costs were less than you would expect for most drugs, where they have to actually invent the compound and then go through years and years of testing. if you had invested in Retrovir 25 years ago, you would probably be sitting pretty right now. But not if you were someone having to pay for this medication out of pocket, or a taxpayer whose money was being used for that purpose. Now, this is a slide from Uganda. I'm sorry to range so widely away from the state. This is what happened to antiretroviral prices in East Africa. Obviously, $1,000 a month. Very few people in Arkansas could afford that, let alone people in East Africa. And there was a strong push to get these drugs available at affordable costs, generic equivalents, etc. And so, almost 10 years before we had our first generics available in the U.S., they had generics available in East Africa, and you can see what happened to the prices there. And then this is a table I put together, and this is maybe just funning around. Don't take me too seriously, but these are actual true numbers. These are comparisons of what it cost in our discounted Arkansas ADAP program compared to our Kenya PEPFAR, President's Emergency Plan for AIDS Relief. Both paid by federal dollars, U.S. tax dollars, both going for FDA-approved products. In Arkansas, with our discounted prices, our least expensive regimen is a little over $400 a month. We almost never use that regimen because it's got a lot of side effects. It's not the strongest regimen that we have, but you could get the same regimen in Kenya for less than $20 a month. If you look at our most common regimen, which costs us a little over $750 a month, in Arkansas, discounted prices, you can get that for a little over $30 a month in Kenya. And our most expensive regimen, which is over $1,000 a month, $62 a month in Kenya. And there are companies that are able to manufacture, distribute, and make a profit off of these at the prices in Kenya. These are not subsidized prices. I'll move on before I start boiling over. Okay, so we've talked about cost, and I argue that cost is a big issue when it comes to access and getting into care. There's also a relationship between cost and HIV transmission. As I mentioned before, we know that people who have their HIV under control are much less likely to pass HIV on to others. A very recent study that was sponsored by the National Institute of Health showed that taking ART consistently, along with other preventive measures, reduces transmission by 96%. Okay, so very low risk of transmission for someone who's taking their antiretroviral medications regularly and taking reasonable precautions. So you can imagine if we had, instead of 28% of those living with HIV controlled, if we had something more like 90%, we would have a lot less HIV transmission. Treatment as prevention. There was a study out of Taiwan. The Taiwan government implemented a policy of providing all HIV-infected citizens with free access to ART. Their rate of new HIV infections decreased by over 50%. Okay? We've been static. We've been the same year after year. In the U.S. total, we have about 50,000 new HIV infections per year. But in Taiwan, back in 2004, they saw a 50% decrease. We know better. We could or should be able to do better. So I'll throw in this just to stimulate your thinking. We've got good medications. We can control HIV like we can high blood pressure or diabetes. Do we even need a cure? And I like this quote: "Despite its success, chronic suppressive therapy is limited by its cost, the requirement of lifelong adherence, and the unknown effects of long-term treatment." And I think we need to rekindle our hope or our aspiration for something more like a cure. We propose that a drug-free remission should be the new goal of HIV therapeutics. And I think this is a great challenge. This was thrown out there 2 years ago, and I think many researchers have taken this up as a challenge. I'll move on to complications, and I don't have a lot of time left, but I don't have very many slides left either, so we should be okay. Early on, when HIV was really conceived of as a terminal disease, when we were talking about complications, we were talking about age-related infections, age-related malignancies, chronic pain, disability. These were the things that were really on my mind as an HIV care provider. As we were able to get HIV under control, the immune system strengthens, these age-related infections became less of an issue, and we were more concerned with things like long-term medication side effects and comorbid conditions, particularly hepatitis. A lot of our HIV-infected individuals also had chronic hepatitis. And I remember a time in about 10 years ago or so when it was no longer opportunistic infections that were the leading cause of death. It was hepatitis as the leading cause of death. Now we've, over the last 10 years, sort of moved maybe a step beyond, where many of our individuals, at least the 28% who are in care and suppressed, aren't really dealing with age-related infections or malignancies, and we're able to manage medication side effects with better options in terms of medications. Many of the comorbid conditions we've been able to manage well. And what we're really seeing is an increasing proportion of non-age-related deaths, particularly from cardiovascular disease and non-age-related cancers. This is a study that looked at a 10-year period of time from 1996 to 2006. The number of HIV-related deaths in HIV-infected individuals decreased dramatically from over 35,000 to less than 14,000 during that 10-year period of time. The AIDS-defining opportunistic infections also decreased dramatically. As a consequence, the non-age-related cancers and cardiovascular disease increased as a proportion of the number of deaths. Particularly the non-age-related cancers increased from less than 3% to more than 7% of the deaths. And you can look at various types of organ disease. If you go down to the bottom, you see heart disease increased from less than 5% of HIV-related deaths to more than 10%. Okay. So today, when I see an individual with HIV infection, we got them on good medications with few or no side effects, they're doing well, their HIV is suppressed. What I'm worried about is heart disease and cancer, hypertension, diabetes, the same thing I'm worried about in everyone else. Because we know that those living with the HIV, even if their HIV is well controlled, they have an increased risk of cardiovascular disease, non-age-related cancers. Now, we're not sure exactly why that is. One of the theories that's out there is that chronic inflammation due to the body's response to HIV infection may have a part to play, and I think probably does. Perhaps some of the antiretroviral medications might make a contribution, but it's clear they're not the sole cause by any means, because we see the same thing in people who are not even on antiretroviral therapy, but still have strong immune systems. Again, this basically shows a similar thing, a different study. Those, the blue and the tan line on the far right, those are the overall deaths and the HIV-related deaths. Those declined, whereas the cancer, non-age-related cancer and cardiovascular disease deaths remained the same, so they became a higher proportion. And among HIV-infected individuals over 55, cardiovascular disease is the leading cause of death. Okay. So when I'm talking to someone living with HIV on antiretroviral therapy, suppressed, I don't breathe a sigh of relief and say, my job as a HIV doctor, infectious disease doctor is over. I'm talking to them about diet, exercise, smoking, healthy lifestyles, cancer screening, all these things that are required for good preventive health. I want to take a moment to talk about smoking. Although it may not be possible at this moment in time for an individual living with HIV to completely eliminate the risk of cardiovascular disease or non-age-related cancer due to their HIV, we know there's a lot of other factors that are in their control. What they eat, how much they exercise, and particularly smoking. There's a very high prevalence of smoking among individuals infected with HIV. And that could be a whole talk on the interrelationship between smoking and HIV. But I just want to stimulate some of your thinking. We know that current smokers with HIV infection have 4 times higher risk of death than those without HIV infection. So what I tell my HIV-infected smokers is, after we get their HIV under control, they're doing well, the single most important thing they can do for their health is to stop smoking. We know that HIV-associated malignancies, as well as many of the non-HIV-related malignancies like lung cancer and a whole host of cancers, colon cancer, etc., are much more frequent in smokers than non-smokers. So an HIV-infected individual who has proper diet, maintains a good body weight, exercises regularly, and avoids smoking will have lower risks of coronary artery disease and cancer than many folks who don't have HIV infection but are overweight, inactive, eat a poor diet and smoke. So these are some things that those living with HIV as well as those who aren't living with HIV can do to dramatically improve their quality and length of life. So we can't forget that and focus totally on HIV. So we've come a long way. It's been slow progress, and we've got a ways to go. But what's next? What's for the next, I won't say the next 30 years, but at least for the next 5 or 10 years, what can we do to improve the situation? I said we know better, we can do better. First of all, get tested for HIV. And I'm not saying we should get someone else tested. We need to start at home. We all need to know our status, and we need to encourage, all those to be tested at least once. It's estimated that only about 10% of folks in the United States know their HIV status. That's, we know better than that. Those who are infected, they need to get into care. We need to figure out better ways to get them into care and to make care more accessible and more affordable. We really can do better than we've done. I'm really hopeful that as the Affordable Care Act rolls out, that will open up a lot of opportunities for more accessible, more affordable care for many living with HIV. And I hope that we're not looking 5 years from now at 60% of our Kansans who know they're infected not receiving any kind of HIV care. That's just unacceptable. I can't believe that we're going to be standing here 5 years from now and still looking at that. It just doesn't seem possible that we would allow that to happen. We need to make HIV care more holistic. It's not just about getting the virus under control, although, we only got 28% who have achieved that, but for those 28%, it's more than just that. It's proper diet, proper exercise, avoiding other risk factors so they can live a long and healthy life with HIV as managed as a chronic disease. But I also remind us that we need to continue to support research towards something that's more like a cure. It's great that we can control HIV long term. I think that's wonderful. But I'd like to see us do something more. We could get something that could actually cure this thing. And I'll leave you with the final thought. We don't have to accept reality. Maybe if we can join together, we can change it a bit. So we're have more progress to celebrate next year or the year after. I'll go ahead and close it. I think there's some time for questions. Yes.
From your premise of we know better, we can do better, what would be one thing you think that you could do better? What's one thing you can do better?
Well, I'll go back. I've put 5 things, but to make them more specific, get tested for HIV. We need to get the word out in as many channels as possible to as many folks as possible, especially those at highest risk. What was alarming to me was to read that African American young gay men, probably the highest risk group that we have right now, are less likely to know their status than heterosexual men. We need to get the word out somehow to in many ways as possible. People need to know their status to begin with. And those who are diagnosed, we need to find ways to link them into care. This idea that we've got, over 5,000 individuals living with HIV in this state who know their HIV status, but barely over 2,000 of them received any kind of HIV care in the last year. Somehow the ball is being dropped. We're fumbling the ball in passing it from diagnosis to care, and we need to come up with innovative ways of linking, community-based screening to, service access, case management. And again, I'm hoping that as elements of the Affordable Care Act roll out, that we'll have new funding streams that will make that possible. As we're looking at payment reform with Medicaid and the other providers, we're really looking at outcomes rather than just services provided. There'll be some real financial incentives to get people into care and keep them into care. Those are 2. I won't spend all the rest of the time, but these are the kinds of things I'm thinking about. But I know there's a lot of smart people here who can probably come up with better ways of doing each of these things.
Dr. Smith? Yeah, my question is, of the 5,300 cases that you have, statistics have seen that African American women were the highest leading groups, but you said with men here in Arkansas. I want to know where the women lead, and then also elderly people, where are they now? Because a lot of statistics are also saying that elderly people are infected more with disease. So I have a 2-part question. Absolutely.
We are seeing dramatic increases in the number of older people who are newly infected with HIV, although the total numbers are small compared to younger folks. But that's one of the most rapidly increasing. And of course, African American women, very disproportionate compared to women of other ethnicities. Huge disparity there. I'm focusing getting way down into details in terms of looking at the highest risk group, and probably our highest risk group in the state are young gay African American men. But that doesn't mean that other folks aren't at risk, and not that we're not seeing dramatic increases in other areas as well.
But once you diagnose them, where are they being referred to? A lot of them are referred to
are service providers for the Ryan White program, our care, Jefferson Comprehensive Care. Some of them, many of them obviously are not getting referred, or they're getting referred and not following up.
Okay, I just have a quick question. With the limited resources and the Affordable Care Act coming out, will those dollars trickle down to the community-based organizations and the grassroots organizations?
I sure hope so. Right now, most medical care dollars go to medical care. We'll stand at the bottom of the cliff and wait for people to fall off. But that's partly a function of our payment incentives, that we have for medical care. We pay for services, and so we get lots of services. There's a major move for payment reform here in Arkansas, and Arkansas is actually leading the way on this, for not just Medicaid, but also Medicare, Blue Cross Blue Shield, some of the other large insurance providers, to move towards models where they are looking at outcomes, episodes of care, rather than just pay for individual services. So providers are going to have to look at outcomes. What's going to get me the best outcome, rather than just how can I bill for the most services. And I already showed you it costs $1,000 a month, which I would argue is too high to begin with, for medication costs for early if you get people diagnosed and into care early, but it's more like $2,000 or $3,000 a month if you wait. So there's an incentive there, and hopefully this is where we can get creative approaches to, hopefully fund community-based organizations to make those links, so we're getting people into care early, and we don't have 47% of our HIV-infected individuals with AIDS.
Dr. Smith, the CDC suggested that testing for African Americans up to age 65. Why don't the primary care physicians or the gynecologists suggest when you go to the doctor that you be tested for HIV? Unless you ask, they're not going to suggest.
Yeah. That's a very good question. The question of why, even though CDC has recommended testing for all individuals, at least between the ages of 13 and 64, they made that recommendation back in 2006. Why 5 years later we still don't have very much testing going on? Some providers are much better than others. There are some obstacles to that. Talking about HIV means talking about subjects that some folks are not comfortable discussing, okay? Some folks have the attitude they would rather not open up a can of worms, or someone else ought to be. That's taken care of by someone else. They should go to the health department for that kind of thing, or whatever. Changing patterns of behavior, takes time. Part of it also is, we really haven't focused on preventive care in our healthcare system adequately. And getting tested for HIV when you're asymptomatic is preventive care.
My name is Renelle Mitchell, and actually I just moved to Arkansas recently, but I'm a retired nurse practitioner from Michigan. And what I wanted to know is, in Michigan, testing for HIV is still voluntary. And as most of you know, if you're pregnant or military or something like that, it's required to have syphilis testing, it's required to have other testing. Is there any move legislation-wise that would start to require people to be tested for HIV if they're in certain situations, like you say, like a pregnancy or like military or something like that? Because when you're saying getting people tested, if you're required to be tested, then a lot of it gets done. But if it's voluntary, like you said, they just don't want to do it. So is there any legislation that would move in that direction?
My comments would depend on exactly what you mean by required. I think requiring healthcare providers to offer testing.
I don't mean offer, I mean if you're pregnant in Michigan, you have to have syphilis testing. It used to be a time when you got married, you had to have the syphilis test. And what I'm saying is, that's how they picked up a whole lot of asymptomatic people, just because in order to get a marriage license, you used to have to be tested for HIV. If you were having a baby, not HIV, I'm sorry, you had to be tested for syphilis.
Sure.
If you were pregnant, you had to be tested for gonorrhea, chlamydia, syphilis, and all that.
Right.
So I'm saying, I know that it's voluntary now, but is there any move, in order to get to your point of getting more people tested, is there any move legislation-wise to work on that?
Maybe just to refine that concept a little bit, I don't mean to be picking on words, but there are some concepts that end up being very, very important. Opt-out strategies, which is what we have here for pregnant women, are very effective. Pregnant woman comes in for care, antenatal care here in Arkansas and most other states. Unless she specifically says, I don't want to be tested for HIV, she will be tested along with the other routine tests. That's very, very effective in picking up the vast majority of infections. The fact that she can opt out, though, is a good thing, because once you tell someone they've got to do something, then the next thing they're trying to do is figure out how to get out of it. I think requiring providers to offer HIV testing in an opt-out fashion to where it's automatic. Most people want to know their status, but they don't want to be stigmatized by asking for the test. And most people want to do the right thing, but they don't want to be forced to do something that pertains to their body that they haven't authorized or don't have at least the power to veto. If you offer HIV testing in an opt-out strategy, very few people opt out. If you try and force people to take it, then what are you going to do if they don't take it? You put them in jail? We're learning about that some with influenza vaccination. This is one of my colleagues at the health department said last night. He said, "Are you ready for tomorrow, December 1st?" I said, "Yeah, I'm ready for World AIDS Day." He said, "No, it's the start of a flu season." So so we're dealing with encouraging people to do the right thing, trying to make it as easy as possible for people to do the right thing, and as difficult as possible for them to do the wrong thing. That's a little bit different than sort of a police state where we're forcing people to be tested against their will. But that's usually not required. When you offer testing, it's part of routine care. Virtually everyone goes ahead and gets tested.
Do you still have to sign saying you're willing to have it?
No. When you sign a general consent for care, that includes all routine care. But you always have the right to refuse certain aspects of care. If you don't want a blood sugar done, you don't have to have it. If you don't want an HIV test done, you can specify. We do that for pregnant women, but we could do that in other settings as well. One setting that would probably be very productive in terms of picking up HIV infections in folks who otherwise wouldn't necessarily be screened or diagnosed is in emergency departments. And there have been some pilot projects that have shown a lot of promise. They've picked up a lot of infections in folks who didn't know they were infected and wouldn't have known if they hadn't been tested in the emergency department. But logistically it's challenging, and many emergency departments have been reluctant to do that because it's not just the testing. You got to counsel and follow up and link people to care. And again, we have a fragmented system, a healthcare system, and we don't. You could hardly even use the term system to describe it. It's a bunch of pieces that are sort of loosely tied together.
My question is, why now is it being detected in elderly people or black elderly? Because they're coming of age where they can get tested by Medicaid or Medicare? Is that why the statistics saying that, you know, it's been detected in them so rapidly now? I mean, I don't understand that question.
The question is, why are we seeing an increased number of new HIV infections in older individuals? I think probably the answer to that is very complex, and I know there are folks who really have a lot of expertise in that area, and I'm not going to try and present myself as an expert in that area, but it does look like older adults are more sexually active with more partners than they were in previous generations. So, but at the same time, they don't think they're at risk. And where we tend to see a lot of HIV infections are in any group of people who don't think they're at risk.
Well, no, you said elderly. I'm not saying, I'm saying, but you said the elderly, you know, that's what, you said sexually active. I don't think that would have nothing to do with being qualified for Medicare or Medicaid, you know what I'm saying? That's the ones I'm looking at. I'm not just looking at like 40 and 50. I'm talking about the elderly. So when you say elderly, I'm looking at 65 and up.
Yeah, we're actually seeing new infections in that age group as well. And I think part of it is people change their behavior, but they don't change their perception of risk. So.
My question is, I know getting people in to have the AIDS test is one thing. What is being done, what kind of research, what kind of educational programs are out there for people that just don't know? I mean, there has to be an educational component. Because a lot of times it's a social thing or a cultural thing. If you don't know, you won't go do it. And for the young black males, if they're in denial that they are gay, they're not going to do that. You know,
absolutely.
For the research that I've done for classes, for men that are in prison or incarcerated for so many years, they say they do what they have to do while they're there. But when I get out, I'm straight. I'm going back to my girls and that kind of thing. But what is being done? What kind of research is out there, or classes to educate in our communities, the grassroots? What type of things are being done?
Well, we know that peer-to-peer communication works well. We know that community-based organizations do a better job of reaching folks in their communities than perhaps healthcare institutions on their own. And we know that social media is very promising in terms of getting the word out about all sorts of health messaging. I think what we need to do is to partner together. We have different components that we know work. I think what we need to do is put the pieces together, and it's probably just not one single answer. We're not talking about a silver bullet here. We're talking about putting together all the best practices and get them to work together. It's hard work, as I guess what I'm saying. That's the tortoise that we got to push from behind. That's an excellent question. Partnership with faith-based organizations. I think there's tremendous untapped potential there. I think involvement of faith-based organizations has been a bit rocky over the last 30 years. There have been times where faith-based organizations have either been part of the problem or been perceived as part of the problem because of stigma. But there have been also situations where faith-based organizations have done tremendous work doing HIV research were young guys. You know, there were no seasoned HIV researchers because, you know, the only guys who were on the HIV bandwagon were the young guys. You know, the older guys had already established their careers in this or that. Now we have, you know, a pretty substantial group of experienced researchers who have learned a lot about this virus and about strategies. So on one hand, I think our prospects for a cure through research are far better than they were 10, 20 years ago, by far. But your other question is, if we had a cure, would it be affordable? And do we have the infrastructure to get it out to people? And I don't know the answer to that. I think I would like to have less uncertainty about that. I would like to think that if we had a definitive cure, that more than 28% of those living with HIV would have access to it. But I don't know the answer to that. I think there's some changes that need to be made to prepare for that day.
Okay, for the sake of time, we have to cut our questions off at this point. We would like to give Dr. Smith a hand, please.
Thank you very much.
Dr. Smith, on behalf of the board and the members of Future Buildings, and all of us that enjoyed this great presentation, we'd like to present you with a certificate of our appreciation.
Thank you very much. It's been a pleasure and a joy.
I'd like to thank everybody for their attention.